So I'll be talking about some special situations like the previous speakers have spoken about. What we have learned is, the IOL prediction has become extremely accurate for routine eyes. But there are certain situations, certain cohorts of patients where we are lagging behind. We are not able to deliver, that 90% result within prediction error of 0.5 diopters. So one of that happens to be the post-vitrectomy situations. Where are the hurdles? These situations, many of these conditions, we find it difficult to measure the axial length, particularly when there is a silicon oil field in the posterior segment. And once we get the IOL power, get the axial length, what are the best formula that should be used for these situations? And then what is the best power? Do we have to modify the intraocular lens power, particularly in patients who have silicon oil still in the posterior segment? And finally, what is the best type of intraocular lens that will give us the most optimal results? The difficulties in axial length measurement is the most important cause of error in IOL power calculation. So in silicon oil filled eyes, if you are using immersion A-scan, there will be an overestimation of the axial length. And if you are measuring the axial length in a patient with a macular edema using ultrasonic biometry, again, there will be an underestimation. Likewise, in a patient with a bullous regmentinous RD, if we are using an optical biometry, then again there is an underestimation that is going to happen. So, how do I sort out this problem in my practice? When a patient with a posterior segment pathology comes for posterior segment surgery, first thing we do is we perform the biometry for the patient. Ideally optical biometry if it is possible, and in certain situations where it is not feasible, then acoustic or the ultrasound biometry, and the results are archived in the hospital and a copy is given to the patient, so that wherever the patient goes later on, patient has got the biometry, pre-vitrectomy biometry available with him. So challenge happens when a patient comes to us, a fresh patient who has already got a cataract with silicon oil in the posterior segment. So I do an optical biometry in those situations. That sorts out the problem. However, in certain situations, for example, a patient who has a very advanced total cataract, thick posterior subcapsular cataract, patient cannot fix it. Optical biometry is not possible. So then I will be resorting to acoustic biometry, and herein the problem lies. See, the silicon oil in the posterior segment reduces the velocity of sound in the posterior segment. So you also get poor retinal echoes, and because if there may be multiple bubbles of silicon oil in the posterior segment, so you may have a shifting or deduplication of the echoes. So ultimately you have, like for example here, these are the echoes from the retina, which is very, I don't know, am I visible on the screen? I'm not able to get my here. Okay. So you need to convert the apparent axial length the true axial length. So now here is a situation. So now here I have a situation where the patient has silicon oil in the posterior segment, and we have used a velocity of 1532 for all segments. This machine has got multiple gates, so you can measure the anterior chamber depth, lens thickness, posterior segment thickness, posterior segment length separately, and using a velocity of 1532. So you get a total axial length of 36.28 millimeters. This is the apparent axial length that has to be converted into the true axial length, and you need to know the velocity of the viscosity of the silicon oil that has been used in that particular case. So for a silicon oil with a viscosity of 1000 centistrokes, 980 meters per second is the sound velocity. For 5000 centistrokes, 1040. So depending upon the velocity of the silicon oil, of sound in the silicon oil, the axial length can be, the distances measured can be adjusted, and ultimately you see that the true axial length is only 25.69, and the apparent axial length was 36.28, and that was actually confirmed by a optical biometry that was done, which again gave an axial length of 25.7 millimeters. But in certain situations, you may not know what exactly was the viscosity of the silicon oil in the posterior segment. Patient who has walked in from outside. So so I would be using, taking a chance, and you would be using various constants. Say, for example, if it is silicon oil of 1300 centistrokes, if the initial surgeon tells me, then I would use a factor of 0.71 and multiply this with the axial length. So these are the problems with silicon oil filled eyes. There are multiple bubbles, And if we have a problem in doing biometry, ultrasonic biometry for these patients, make these patients sit up, in this position, so that, you don't have the patient, the sound beam does not have to encounter multiple interfaces. Don't do it in the supine position, do it in the patient, with the patient sitting up. Now, sometimes, all said and done, if nothing works out, you cannot measure the, ultrasonic biometry also doesn't give an axial length. There are reports in the literature where CT scan has been performed, MRI has been done. These are very expensive. Some of them may be very accurate, but they are not feasible. We have taken axial length of the fellow eye or a standard power. So I don't think this is really advisable, but these are the things which you see in the literature. And after silicone oil removal, like after the silicone oil is removed, you refract the patient and then find out what is the best IOL power for the patient. Now, this is a patient where silicone oil has been removed and the intraoperative biometry was done. Eye was pressurized with an infusion and then appropriate IOL power was calculated. So this is another another thing that could be easily done. The same person, Dr. Saurabh Padwardhan, I think, who has done that particular device you're talking about, So he, their study has suggested that if you do the retinoscopy after removal of the silicone oil on the surgical table and multiply the retinoscopy value by this factor, you get the IOL power and implant that particular IOL. So there are various other options, various other studies, which almost suggest the same thing, multiply by 2.01, multiply by 1.75. So now you have got the axial length of the particular patient, with lot of difficulty. Now how do you choose the intraocular lens power for this patient? Now, these patients have got silicone oil in the posterior segment, and silicone oil has a higher refractive index than vitreous. So this means, it converts the eye into a hyperopic refractive error situation. So you need to adjust the intraocular lens power. Now, it has been shown that, the hyperopic changes that happen, it depends upon the shape of the lens. If you have a biconvex lens with a lot of convexity on the posterior curvature, you have a maximum hyperopic shift. If you have a plano-convex lens, unfortunately, plano-convex lenses are not available in the foldable format now, or a meniscus lens where the posterior surface is concave facing towards the retina, that reduces the postoperative error. So, how do we look for the lens power? How do we fix the lens power? This situation happens when the posterior segment surgeon wants a silicone and fill the posterior segment. The retina requires the silicone oil, and you have done an intraocular lens. So if I'm using a biconvex lens for this patient, and this is what we routinely use, for any lens more than 20 diopter, you have to add 8 diopters. Say, for example, if my IOL master gives me a lens power of 20 diopters, in this patient, I'll be using 28 diopter IOL. Otherwise, the patient will have a bad hyperopic shift. And once the silicone oil has to be removed, we remove the silicone oil and patient will have a myopic shift. So this has to be explained to the patient beforehand. Proper counseling has to be done. And that can be treated with maybe, IOL exchange, or it can be laser, or it can be treated with corneal refractive procedure. And so, but IOL power adjustment has to be made when you have silicone oil fill in the posterior segment. So this has been amply proved by many studies, what exactly is the quantum of IOL power that you need to modify. And as regards formulas, now newer and newer formulas have been coming up. So now, which formula to use for which situation? Again, I scan the literature and this is what we follow. See, now we have patients undergoing vitrectomy with very good prognosis. Macular hole, epiretinal membrane, vitreous hemorrhage, otherwise normal posterior segment. So post-operatively, it is really necessary for us to give a very accurate and precise post-operative outcome for these patients. So each and every aspect of your calculation exercise is important. Now, for patients who have, if you are performing, phacoemulsification patients who have undergone a vitrectomy, so this particular study compared the newer formulas and the traditional formulas, and found out that the traditional formulas, if you have done a Weinkoch adjustment for the axial length, and the newer formulas, they do pretty well. Now, if you are combining phacoemulsification with silicone oil removal, in that case, the EVO formula also does extremely well, but most of the newer generation formulas also do pretty much well. And situations where epiretinal membrane peeling and for that vitrectomy has been done, phaco plus vitrectomy. So here, the Kane formula has done extremely well, but that does not mean the other formulas cannot be used. Kane formula has done extremely well, and Barrett Universal 2 and Heal RBF. So what I do in these situations is I calculate IOL power using all the formulas, and most of the time the formulas tell me the same result. If there is a change in the result, then I use the Kane formula because it has been proved for more than 5 years that it has given good results. So friends, I think how much time do we have? 42, yeah. So so cataract surgery, IOL implantation in eyes with posterior segment conditions are no longer a very challenging situation. Is no longer has become very demanding. Like unlike in the previous days, now vitrectomy is being done for very good prognosis eyes. So we have to make sure that use the best technology, best surgical technique, best strategy for IOL calculation for these patients. And in certain patients, of course, in spite of a best effort, if the patient has a very disorganized posterior segment, your best results may not really be very well appreciated by the patient. So in spite of that, you must use the latest technology techniques, use the current concepts and the newer formulas to give you the best